This is Dr. Selby. We're going to be talking about an approach to patients with oliguria and or proteinuria. This is a learning objective. You can see as far as diseases we're going to specifically talk about, we're going to talk about chronic kidney disease, acute kidney injury, nephrotic syndrome, and nephritic syndrome. These are potential topics you can go back for reference. You can look at Harrison's, which is probably the best for your level. I am a nephrologist, so again, your obligatory kidney picture. So let's talk about a few definitions before we get into things too much. What is anuria? Anuria is when the urine output per day is less than 50 or 100 milliliters per minute, so essentially nothing. Oliguria, which means low urine output, is when your urine output is less than 4 to 500 milliliters per day. Polyuria is when the urine output is greater than 3,000 milliliters per day, or 3 liters per day by definition. What's azotemia? Azotemia means you have an elevated blood urea nitrogen but no symptoms of renal failure, whereas uremia means you have elevated BUN but with symptoms. And what are symptoms of uremia? Nausea, vomiting, confusion, pruritus, which is itchy skin, a metallic taste within the mouth, fatigue, anorexia. There are many more. But all of these symptoms are non-specific, and you have to understand that just because a patient has an abnormal kidney function and they have these symptoms does not mean they're uremic, so you have to try to interpret it with a little grain of salt. What would be the basic differential diagnosis if you were seeing a patient with oliguria or proteinuria? Well, if you thought about it in a cardiac, pulmonary, renal standpoint, since that's the course, I would wonder if they have something called cardiorenal syndrome because of ineffective blood flow or decreased effective circulating volume. The kidney feels starved of blood, so we call that cardiorenal syndrome. There are different subtypes. You can have valvular problems that can do it. You can have cardiac tamponade, which can do it. You can have vasculitis problems that affect the lung. Common ones would be NPO, PR3, or Scherg-Strauss. You can have anti-GBM disease or Goodpasture disease. You can have liver failure, which can cause hepatorenal syndrome. Or you can have something called prerenal azotemia. So the effective circulating volume is decreased because of hypovolemia, because of these reasons, or cardiac shock, or neurogenic shock, or sepsis. We have acute kidney injury. So that's broken down to prerenal azotemia, which we talked about, but it's also known as intrinsic renal dysfunction, with the most common reason being ATN, or there's an obstruction, post-renal obstruction, or the patient has CKD. And the big causes of CKD in the U.S. are hypertension, diabetes, acute kidney injury, or they have end-stage renal disease, ESRD. What are questions you may want to ask your patients? Have you been drinking enough fluids? And when I say fluids to my patients, I include water, coffee, tea, soda, everything. A lot of patients interpret that to mean just water. Pardon. Normal fluid intake is around 1.5 to 2 liters a day. Another way of saying that to your patients is about 50-60 ounces of fluid a day. Other questions that are helpful is you could ask the patient, do they have any signs of orthostasis, or are you lightheaded or dizzy with position changes? Do you have a history of hypertension? If so, how long? What's your typical blood pressure at home? Is it controlled? Is it not controlled? Do you take your medicines regularly? Do you have diabetes? If so, for how long? Is it controlled? What was your last A1C? What medicines are you taking? What other complications do you have? Do you have any retinopathy? Which, if patients have diabetic retinopathy, which is a microvascular complication, they very likely have kidney disease, which is another microvascular disease. Are you using certain medicines that can affect the kidneys? So what we call nephrotoxins. Examples would be NSAIDs, aspirin, ibuprofen, Motrin, Aleve, Excedrin. so on, Mobic, meloxicam, Celebrex, ketorolac. Are you taking any antibiotics, or have you recently taken any antibiotics? Are you taking a proton pump inhibitor? Very common in people with GERD. Examples are like Protonix, Prilosec. If yes, which ones are you taking? How long have you been taking them? For days, weeks, months, years? A lot of people will tell you that they've taken ibuprofen on and off for most of their life, 4 to 5 times a week with 4 to 5 pills at a time throughout the day. You can ask them, have they had any recent IV iodinated contrast? Iodine-based contrast dye is potentially harmful to the kidney. It can cause contrast-induced nephropathy. So examples of when people would get this: cardiac catheterization. So they have a heart cath, or they get a CT scan for whatever reason, they can get IV dye. Oral contrast does not count, just the IV, and it's only for a CT scan if it's a CT-based dye. MRIs give gadolinium. Gadolinium is not necessarily associated with acute kidney injury or CKD, although there are case reports of that, but not a common cause. Ask them if they empty their bladder. Do you retain urine? That could be a sign of BPH or a neurogenic bladder, etc. Is there anyone in your family who has kidney disease? So anyone that has blood in the urine or protein in the urine, or a history of kidney cysts, which could be a sign of polycystic kidney disease, or someone that has a history of kidney disease like CKD or end-stage renal disease, or anyone that required dialysis. Sometimes you have to ask the question multiple different ways to tease that information out. What are things you would want to look at on the exam? Well, you'd want to look at their volume status. So are their jugular veins flat, hypovolemia, or distended, heart failure? Is their mouth dry? Is their tongue fissured, or is it nice and moist? Is their capillary refill less than 3 seconds, which is normal, or is it above that, suggesting volume depletion? Although if someone has heart failure, you have to be careful with that. Do they have skin tinting or abnormal skin turgor? And in the elderly, it's best to pinch their forehead. Their elasticity seems to be best there. Do they have signs of heart failure, an S3 or crackles? Do they have ascites, which might be suggestive of heart failure or cirrhosis? Or do they have edema? Or do they have sacral edema? So this is often where, if you're in a hospital, you can look at someone's legs or arms. They seem to be euvolemic, but when you have them lean forward and you push on their sacrum, you see quite a bit of fluid. You can look at their eye, particularly if you're in the outpatient clinic and you have an otoscope. Ophthalmoscope, not otoscope. You can look to see if there's hypertensive or diabetic retinopathy. If you were worried about ANCA vasculitis, you could look at their nasal mucosa to see if there's any ulcer or crusting. If you're worried about what we call a post-infectious GN, you could look for if there's any tonsillar exudates or signs of a recent upper respiratory infection. Cardiac, again, you could look at the S3 of the heart failure. Lungs, you can listen for crackles. Do they, is that pulmonary edema, or is there an interstitial disease going on, or do they have an effusion? In the abdomen, you want to listen at the renal arteries, which are above the umbilicus on each side. You want to see if the kidney is palpable. If they have a transplanted kidney, it's usually in the right lower quadrant, although it can be in the left lower quadrant. Is their abdomen tense? If they have a really tense abdomen, perhaps they have abdominal compartment syndrome, where there's fluid compressing the renal arteries and preventing blood flow. You look for skin rashes. You can look for signs of autoimmune disease like synovitis or myalgia, or see if they have CVA tenderness, which might be suggestive of a urinary infection, or perhaps kidney stone. So let's talk about chronic kidney disease. It's not chronic renal insufficiency. It's not chronic renal failure. The correct terminology these days is chronic kidney disease. You will hear people when you're out on rotations that will refer to it as chronic renal insufficiency or renal failure, but technically that is not the preferred term. How do you diagnose someone with CKD? Well, they have to have one of the following criteria present for greater than 3 months. So the first one is a marker of some sort of kidney damage. So that can be protein in the urine, predominantly albumin, or some sort of abnormal urinary sediment, so red cells, white cells in the urine, granular cast, things like that. They could have an electrolyte abnormality that you think is due to a tubular disorder, so maybe it's an RTA. Maybe you've done a biopsy, and on the biopsy they have abnormal histology, so that would be a way. Or on imaging, they have abnormal imaging, or they have a history of a kidney transplant. Just having a kidney transplant will give them CKD, even if the transplanted kidney has a normal GFR. The other way is looking at the GFR. If the GFR is less than 60, and again, this is all for 3 months, they have CKD. So either criteria are necessary for 3 months. So if a patient, if it's been less than 3 months where the GFR is less than 60 or they have markers of kidney damage present, then the patient has acute kidney injury. After 3 months, we change the terminology and we state that that patient has chronic kidney disease. Here are stages of chronic kidney disease. It's all based upon the GFR. So stage 1 is greater than 90. Stage 2 is between 60 to 90. So you can see they typically go by 30. So 60 to 90. Stage 3 gets broken up into stage 3A and B, which is really not clinically relevant. It's more for research, but it's 45 to 59 or 30 to 44. Stage 4 is 15 to 29, and stage 5 is technically less than 15. In the absence of kidney damage, neither GFR category stage 1 or 2 is enough to fulfill the criteria of CKD. So if somebody has a GFR of 70 or 120, but they don't have proteinuria or hematuria or some sort of marker of kidney damage, they don't have CKD. Okay? What are the causes of CKD? CKD is predominantly caused by diabetes and hypertension. You can have glomerulonephritis, which is just inflammation of the glomerulus, which is caused by a multitude of different diseases, but that's not the main cause. It's diabetes and hypertension. Then there are other diseases that can do it, something called chronic interstitial nephritis or obstruction or cystic hereditary diseases or vasculitis, and then about 5% of the time we just don't know. What are the ways of presentation of CKD? Well, it really depends on the severity. Okay, most patients that you're going to see are going to be asymptomatic, and the only reason that you know they have kidney problems or they know they have kidney problems is because they did routine blood work that showed their creatinine was abnormal with an abnormal GFR. What are signs and symptoms of CKD? If the GFR is low enough, they can have edema. Certainly they can have hypertension, decreased urine output. Foamy urine is a nice clinical thing that you can ask patients. They have a lot of bubbles in their urine. It can be a sign of excessive proteinuria. Uremia we've gone through, which is the symptoms of elevated BUN. You can have a pericardial friction rub, which is a sign of uremia. So that can be from pericarditis or pericardial effusion. You can get asterexis, which is a neurological sign where you get this hand flapping. So if the patient extends their hand back maximally, you'll see that it flaps, it moves down like this. And then you can see something called uremic frost. Uremic frost is caused by some urea crystallizing in the skin. This is for people that have really high levels of urea. Not something we see that common anymore. This is a figure of the signs and symptoms of uremia from a New England Journal article if you'd like to read through them. How do you diagnose CKD? Well, serum creatinine is a poor marker of kidney function, but it is something we use frequently. More commonly, we use creatinine in conjunction with the GFR, and we estimate the GFR, eGFR, and we do that. There are lots of different mathematical formulas you can do it. One that's commonly used is the MDRD equation. More recently, there's an equation called the CKD-EPI. All of these equations have limitations, and in fact, they're not that accurate in people that have rapidly changing creatinines. So if someone has acute kidney injury, the estimated GFR is likely abnormal because the formulas were based upon people that were in steady state, so a normal amount of creatinine being produced and removed from the body. Okay? I can't tell you how many times I've had a pharmacist call me and say, hey, this patient's got a creatinine of 6, yesterday it was normal. What do you think their GFR is? And my advice is, I have no idea. I would often tell them that it's less than 30 or less than 10, depending on what the urine output was. Then there's something called measured GFR, where you can actually measure the patient's GFR, but it's only a measurement at that given minute. So on July 8th at 3:26 p.m., this patient had a GFR of 100 milliliters per minute or 20 milliliters per minute. So it's an easy way of getting it. Only certain institutions can do it. The most common way of doing it is something called an iothalamate clearance. Then there's creatinine clearance. So this is a way of estimating the GFR. Creatinine clearance is not the same as GFR because, as you remember, creatinine is freely filtered at the glomerulus, but it's also secreted by the tubules. So when you measure the amount of creatinine in the urine, it's often higher than the true GFR because some of it was secreted by the tubule, not filtered by the glomerulus. So you have to remember that that tends to overestimate it. There's something called the Cockcroft-Gault equation. This is the formula here. It's not used all that much. It's used predominantly in medications. That's how they estimate what GFR that you can give a medicine at. You can do a 24-hour urine collection for creatinine clearance. The problem with this, it's a cumbersome thing. If you've ever asked someone to collect their urine for a whole day, it's difficult. And patients tend to over-collect or under-collect. So what the total volume you get is not that accurate. So it makes the number not that accurate. So I don't do it unless I have to. Then you can look for proteinuria. Proteinuria, the main way of defining it these days, we do a random urine albumin creatinine ratio or a random urine protein creatinine ratio. And so these are easy to obtain. The reason the creatinine is there is to take away the difference of urine volume. So if you think about it, if I asked a patient for a random urine albumin sample and they gave me a small urine cup that had 10 milliliters of urine, I'm going to have whatever number of albumin present. But if the next day I ask them to do the same thing but they only give me 5 milliliters of urine, I might have less albumin in the urine, but that's because I have less volume. So the creatinine helps normalize the amount of protein in the urine sample from the volume. So that's why we measure creatinine, to help normalize the albumin to creatinine or to the volume. You can do a 24-hour collection. Same thing with the 24-hour collection for creatinine clearance. It's cumbersome and patients struggle for accuracy. Urinalysis is a key to the diagnosis, and I often want a microscopy, so we look under the microscope to see if there's any abnormal urinary sediment. So these 3 simple tests, so if there's a box on a screen, you need to know it, will identify CKD in most patients. eGFR, urine albumin creatinine ratio, or urine protein creatinine ratio. Albumin is just more specific to the kidney. This is all protein. This is just albumin. And urinalysis. You can diagnose CKD based upon renal imaging. The most common imaging done is renal ultrasound. This can evaluate the size of the kidney, can look at the thickness of the cortex of the kidney, see if what we call increased echogenicity. can also see if there's any obstruction, where we see hydronephrosis, where there's fluid backing up into the kidney, and so the urinary renal pelvis is dilated. You can see if there's a mass or a cyst. Lots of cysts might be indicative of polycystic kidney disease. You can also look at the Doppler renal ultrasound. So this is where you look at the blood flow in the renal arteries to see if there's any narrowing or if there's perhaps a thrombosis. So there's something called resistive index. You don't need to know that too much, other than the higher that is, the more impairment there is to blood flow within the kidney, which is a sign of CKD. You can do a CT scan. It's a little bit better at detecting masses and kidney stones. Essentially, it's used for the same thing as renal ultrasound. MRI can also be done. It's usually better for renal masses. And there's other testing you can do. You can do a MAG3 renal scan, other things like that. We won't get into it. In general, on a renal ultrasound, which is the main way people are going to diagnose CKD, if there's atrophy or small kidneys, that's a sign of CKD. If there's cortical thinning, that's a sign. If there's increased echogenicity, that's a sign of CKD, non-specific. Elevated resistive indices, sign of CKD. So these are all signs of CKD on renal ultrasound. What are the complications of CKD and how do you treat it? Well, often they'll have protein in their urine. Protein in the urine long term is toxic to the kidney and will cause kidney function to get worse. So you can put them on a low salt diet, which will reduce protein in the urine. You can control their blood pressure, and you can put them on certain medicines that reduce the amount of protein present in the urine. Most of them are going to be blocking the RAS system. The non-dihydropyridines, so verapamil, diltiazem, have some effect. You want to control their blood pressure. Their blood pressure goal depends on whether protein is present. They're at high risk of heart disease, so you want them to be on a statin. If they're anemic, because the kidney makes erythropoietin, which stimulates bone marrow to make red cells, so as kidney function goes down, there's less erythropoietin present, so people tend to get anemic. You can put them on iron, oral or IV, or you can give them erythropoietin back exogenously, and we call this ESA, erythropoietin stimulating agents. Examples, Aranesp. If they're acidotic, sometimes we'll give them bicarbonate, because we know that metabolic acidosis can worsen CKD or cause progression of CKD. If they have hyperkalemia, we'll put them on a renal failure diet, which is probably one of the worst diets you can be put on. It's a low salt diet, low potassium diet, and a low phosphorus diet, so essentially everything. You can give them a diuretic, predominantly a loop diuretic, to waste potassium, or you can use these binders that will exchange potassium with other electrolytes within the gut on these exchange resins. Often patients will get what we call CKD BMD, bone mineral disease. Previously we called it renal osteodystrophy. So what happens is phosphorus levels go up because phosphorus is primarily excreted by the kidneys. Calcium levels go down. This stimulates parathyroid hormone to release, or parathyroid to release more parathyroid hormone. So we call this a secondary hyperparathyroidism. So long term, this can cause bone thinning. So we want to keep phosphorus controlled. So we will put them on a low phosphorus diet. In the renal diet, we'll put them on a binder. So they take a medicine that binds the phosphorus in their food when they're eating, so that they poop it out instead of absorbing it. Foslo would be an example. Rinvella would be an example. Sometimes we'll give them vitamin D. Vitamin D can inhibit PTH secretion. We can give them something called a calcimimetic, cinecalcet, or also called Sensipar, which lowers PTH secretion. Or we can put them on dialysis to control their phosphorus. That's an extreme move, just to control phosphorus. And if they're volume overloaded, you can give them diuretics or restrict their fluid, or put them on dialysis to remove fluid. So how do you treat it? Well, there's renal replacement therapy, which means that there's hemodialysis, peritoneal dialysis, or transplant. And transplant can be from a living donor or a deceased donor. So someone could donate one kidney. You only need one kidney to live. So I could donate one of my kidneys to a patient and do fine. This is the indications for dialysis. I would have you memorize it, not because you need to be the one starting dialysis, but to know when to necessarily call a nephrologist. The mnemonic is AEIOU, the vowels, so acidosis, electrolyte problems, ingestion, volume overload, or signs of uremia or symptoms. I will tell you that these are not absolutes, so I may see a patient who has potassium that's 5.9 or 6.2. I'm not going to necessarily put them on dialysis for that. So you have to kind of take it with a grain of salt, but these are a starting place of when you would consider dialysis. Now let's talk about acute kidney injury. So it's not acute renal insufficiency, it's not acute renal failure. Just like CKD, it's acute kidney injury. Okay, that's the proper term these days. How do you define it? Well, there are different stages of acute kidney injury. They're based upon your serum creatinine or your urine output. So stage 1 would be a change in serum creatinine of 1.5 to 1.9 times normal, or an overall increase of 0.3 milligrams per deciliter in creatinine. Whereas stage 2, it's a little bit more, okay? Or a change in the urine output. Whatever is worse is what stage you are. Stages of acute kidney injury, in my opinion, are not that helpful. I don't need to say when I'm in the hospital that a patient has stage 3 acute kidney injury. Some people will put it in their notes. A lot of clinicians like to use it. It's more for research than it is, in my opinion, for clinical help. But I want you to be familiar with the stages. Oops. And then there's postrenal. Postrenal means that there's some sort of obstruction. The urine is made properly in the kidney, but it can't get removed. It backs up and puts pressure on the kidney. So the patient could have a bladder outlet obstruction because they have an enlarged prostate, or bladder cancer, or a urethral stricture, or they have lots of blood clots in the bladder, or they have ureteral obstruction. So it's either unilateral and let me say this again. So ureteral obstruction can cause postrenal acute kidney injury, but it typically has to be both ureters involved, bilateral. The only time unilateral obstruction will cause renal failure is if you only have one kidney. And it can be from stones, malignancies, something called retroperitoneal fibrosis. So what happens is you get all this scarring of the retroperitoneum, and the ureters are in the retroperitoneum, and so they get compressed. You can also see it in papillary necrosis. So this is in the renal pelvis, so people that take NSAIDs. So how do people with acute kidney injury present? Very similar to chronic kidney disease, in that the severity of the acute kidney injury depends, or the symptoms depend on the severity of the acute kidney injury. Most patients don't have any symptoms. Some can have mild symptoms to very severe. Again, edema, hypertension, low urine output, whether it's complete anuria to oliguria to non-oliguria. They can have foamy urine, they can have blood in the urine, which is gross, that they can see. They can be short of breath if they have pulmonary edema from volume overload. They can have uremia, which could be signs would be a pericardial friction of asterexis or uremic frost. Here are more symptoms. This is uremic frost. So what do you do? How do you diagnose it? Well, on all patients with acute kidney injury, you better get a urinalysis with a microscopy. If you don't, you're missing out. And you better get, at minimum, a random urine albumin creatinine ratio or urine protein creatinine ratio. And then anything else you do beyond that is going to be based upon the individual case. So you could get an ultrasound. You could look at the BU and creatinine ratio. If it's greater than 20 to 1, that's suggestive of a pre-renal azotemia. You can look at fractional excretion of sodium or urea. This is the formula, either sodium or urea. And if it's less than 1%, we say that's pre-renal. If it's greater than 2%, we say that's ATN. Fractional excretion of urea is used in substitution of fractional excretion of sodium in patients in whom the sodium content in the urine has been affected or altered. So the patient's on a diuretic that increases urine sodium levels, or the patient has been given IV fluid, which may increase urine sodium levels. Neither one of them are all that effective, and we'll talk about this in a second. Urine eosinophils is another test that can be done. For the most part, not a necessary test. And for people with really severe kidney disease, or you're just not sure what's wrong, you may want to do a renal biopsy. But in general, the red box, this is what you need to do. You need to do an ultrasound, you need to do a urinalysis, urine protein studies, and possibly an ultrasound. Those are the main ones that you're going to do as a student or general practitioner. What are the complications? Complications can be hypervolemia from excessive fluid status. You get pulmonary edema, heart failure. You can have any of these electrolyte abnormalities. Your uric acid level can go up. You can be uremic. You can become acidotic. If your platelets are if your BUN is above 100, you can be at risk of bleeding because of platelet dysfunction. And you may need dialysis. The treatment of acute kidney injury depends on the cause. So in general, if they're pre-renal, you need to restore their volume status, which typically means IV fluids. If they have ATN, you usually just have to give them supportive care. If they have glomerulonephritis, you may have to give them immunosuppression or plasmapheresis. That would be up for the nephrologist to decide. If they have interstitial nephritis, usually medication related, you need to stop the offending agent, and you may want to give them steroids. In general, you try to correct the underlying disease causing the problem. So if they have heart failure, you make the heart failure better. If they have liver failure, try to make the liver function better. It's mostly supportive, so you want to avoid hypotension, stop nephrotoxins, antibiotics, NSAIDs, ACE inhibitors, proton pump inhibitors, IV contrast. Renal replacement therapy may be needed, and that can be in the form of hemodialysis usually. Overall, time is nephrons. The sooner you fix things, the better. Nephrotic syndrome. Nephrotic syndrome is when you have quite a bit of extra protein in the urine along with other symptoms. Let's talk about it in more detail. What's the actual definition? It's protein in the urine. Usually it's greater than 3.5 grams per day with low albumin, because the albumin in the blood is being lost in the urine. So the albumin level goes down. You have to have hypoalbuminemia. Typically you have peripheral edema, your triglyceride levels go up, and you have fat in the urine, lipiduria. So the key point here is if the serum albumin is normal and you have nephrotic range proteinuria, then you do not have true nephrotic syndrome, but instead nephrotic range proteinuria. And the reason I bring that up is because it helps with the differential diagnosis. There are different things that cause you to have nephrotic range proteinuria but normal serum albumin. Something like secondary FSGS, which you don't need to know, it's just an example. What about nephrotic syndrome complications? Well, edema is a big one. And the question is, why do people develop this edema? Is it because they have a low serum albumin, or is it more likely because they have an increase in the amount of sodium retention in the body? And we'll talk about this. Either way, you get an increase in total body water and sodium. Or is it other complications include hyperlipidemia? We don't really understand why people with nephrotic syndrome get hyperlipidemia, but it's probably because of the low oncotic pressure from the low albumin stimulates hepatic lipoprotein synthesis and gives you this elevated lipid level. It can also put you at risk of infection. The reason you're at risk of infection is because you're losing antibodies, predominantly IgG. So it's not uncommon with patients with nephrotic syndrome that you can check a total IgG level and it'll be low. And occasionally you'll want to treat that by giving them IVIG, which is a way of replacing their IgG levels. Thrombosis is a risk of nephrotic syndrome, and we don't really know why. We know that the thrombus can be either on the venous or the arterial side. It seems to be higher, the risk is higher with the risk is higher with the lower the albumin. So once the albumin is less than 2, or some people say 2.5, you're at higher risk. And Why is this? In general, you lose in the urine antithrombotic factors, and you have an increase in procoagulant factors. And so these are patients that are considered at highest risk for venous thrombosis or arterial thrombosis, low albumin, hypovolemic, in bed, and if they have membranous nephropathy, which is the most commonly associated glomerulonephritis with thrombosis. Other complications, you can get a vitamin D deficiency, and that's because you lose in the urine something called vitamin D binding protein, which is a protein that helps transport vitamin D throughout the blood. So it's not uncommon. You check their total 25 vitamin D level and it's low, and you have to give them tons and tons of vitamin D. Anemia is another complication you can see, and that's because you're losing transferrin and erythropoietin, which are necessary for iron transfer, for red cell production. So why do these patients get edema? Well, there's two theories. There's the underfill theory that states they have low intravascular oncotic pressure, and then there's the overfill theory that states they have the kidneys have this innate retention of sodium for whatever reason, probably because the effective circulating volume is a little bit low, so that activates the RAS system, which leads to sodium retention. And this is a figure, so you get proteinuria, leads to hypoalbuminemia, which decreases your intravascular oncotic pressure, you get swollen, or the kidney just keeps a lot of sodium there and water. The presentation of nephrotic syndrome is quite variable. The classic presentation is patients will have new onset hypertension, new onset swelling, which can be very severe, anasarca, which is just gross global swelling of the body. They can have shortness of breath from pulmonary edema or pleural effusions. They'll have proteinuria, so they'll complain of foamy urine. When you do a 24-hour urine collection, it's usually greater than 3.5 grams per day. On urinalysis, you'll see fat in the urine, usually free fat or fatty cast. If you check their fasting lipid panel, it'll be elevated. And there's usually not much blood in the urine. There can be, but not much. And they may or may not have renal failure. And that can be in the form of acute kidney injury of chronic kidney disease, depending on how long they've had the glomerulonephritis. So what's the differential? Well, diabetes is the number one cause of nephrotic syndrome in the U.S. And then in children, you'll see minimal change disease, also known as lipoid nephrosis or nil disease. FSGS, focal segmental glomerulosclerosis, is often seen. There's several different subtypes. A subtype known as collapsing FSGS is typically seen in HIV, which is a common board question. Membranous nephropathy is something that can be what we call primary or secondary. If it's secondary, it's often associated with a malignancy, and this is again the one that's commonly associated with thrombosis, and particularly the renal vein. And then there's a multitude of monoclonal diseases that can affect the kidneys, so multiple myeloma, amyloidosis, or something called monoclonal immunoglobulin deposition disease. And you don't need to know all these subtypes. All you need to know is that monoclonal disease, so you have a plasma cell that's replicating itself and producing light chains or heavy chains or a combination of both, that when those chains are deposited in the tissue of the kidney, they can cause various different effects, from multiple myeloma to amyloid to this MIDD. And there are many more diseases you just don't really need to know because you're not a nephrologist. How would you diagnose it? Well, you can check their creatinine to see what their kidney function is. You can look at a urinalysis to see if there's blood or white cells or protein in the urine. You can get a random protein collection to see how bad the protein is, or a 24-hour collection, which is more accurate but cumbersome. And then there's a whole bunch of blood tests that you can do to try to rule out some diseases. They're not definitive, they're just suggestive. And the most definitive thing you can do is a kidney biopsy, and this is what it looks like. This is a spring-loaded little needle. So you twist the cap, and then there's a button on the top, and it pushes a needle out this device into the kidney and then back in. And if you took a sample which is about the thickness of a head of a pen and looked under a microscope, you would see this. This is a glomerulus, a gross-looking glomerulus under the low power of a microscope. If you see this, this is the striated tissue, that's the medulla, and you don't want the medulla, you want the cortex. The cortex is what contains the glomerulus. How do you manage nephrotic syndrome? Well, you want to treat the underlying cause, and that may or may not require immunosuppression. For the edema, you want to restrict their sodium and put them on diuretics. For the protein, you want to put them on ACE inhibitors or ARBs or other antiproteinuric drugs, and you want to keep the blood pressure low. You want to put them on a statin, and this is management regardless of the cause of nephrotic syndrome to help treat the hyperlipidemia. You want to put, if they have a thrombus, you can consider putting them on heparin or warfarin. I don't routinely do this. Some docs will do it when the albumin is less than 2.5. To me, there's some risk, and you need to be careful with it. If there's infection, you can give them IVIG to help supplement their IgG deficiency. You can give them vitamin D supplementation. And the goal of this talk is not to have you be able to diagnose the cause of nephritic syndrome or the cause of nephrotic syndrome. It's to recognize the urinary pattern and clinical presentation so that you can get the patient to a nephrologist who can then do the subsequent evaluation. Nephritic syndrome, by strict definition, has hematuria and hypertension. Those are the two required diagnostic criteria. They often have protein in the urine, but it's less than what you see in nephrotic syndrome. It's less than 3.5 grams per day. And they often have renal failure. So we say that this is an active urinary sediment. Okay, they have hematuria, which is usually dysmorphic red cells. They kind of look like Mickey Mouse with little ears, where you have red cell cast, or white cells, or white cell cast, or granular cast, and I'll show you pictures of these. On the contrary, nephrotic syndrome has what we call a bland urinary sediment. We just don't see this stuff. So what's the clinical presentation? Again, it's very variable. It depends on the severity of the underlying nephritic syndrome, okay? New onset hypertension, new onset hematuria. Often it's microscopic. They don't know they have it. Occasionally they'll say, oh, I have gross blood. I can see blood when I pee. And that's typically after they have an upper respiratory infection. And you can see that in IgA nephropathy, or what we call post-infectious nephropathy. You can have acute kidney injury, depending on if they have a rapidly progressive GN, which can occur over days to weeks. And then again, protein in the urine, which can be foamy, but usually less than 3.5 grams per day. They can have edema, but it's typically less than what you have in nephrotic syndrome. This is the differential diagnosis, and you don't have to memorize it. Okay, it's just to show you what is out there. IgA nephropathy, very common. Most board questions will have it as a young Asian female because it typically occurs in Asians. There's something called thin membrane nephropathy, Alport nephropathy, MPGN, lupus, anti-GBM or good pasture disease, post-immune vasculitis, all kinds of things, okay? This figure is to show you that there is overlap. So not every disease that causes glomerulonephritis is always going to be nephritic or nephrotic like I told you. For instance, diabetes is one of the most common causes of nephrotic syndrome in the U.S., but it can also have some nephritic features. So sometimes you'll see hematuria in patients with diabetic nephropathy, but that doesn't mean they have another process. Vice versa, maybe you have someone that has a a post-infectious glomerulonephritis, which is routinely described as a nephritic disease, but maybe they'll present with nephrotic features. They'll have far more protein in the urine than you anticipate. So you just have to understand there's a lot of overlap, and that this is kind of an artificial thing where we drew the line in the sand and said, you know, these diseases are more nephrotic and these diseases are more nephritic. You can have overlap. How do you diagnose it? Just like nephrotic syndrome. This is supposed to say nephritic syndrome. I apologize. Same thing. Um, Renal biopsy is the most definitive. And how do you evaluate it from a serological standpoint? These are the things you can do. I'm not asking you to memorize it. I'm just saying that these are things that often the nephrologist will order if they're concerned. Again, you don't have to memorize it. I'm just pointing out that this is a nice way of differentiating the cause of nephritic syndrome. And then this is something I would ask you to try to memorize, the urine microscopy clues of what's going on. So if you see this urinary pattern, you would think this. So if you see renal tubular epithelial cells or transitional epithelial cells or what we call granular cast or waxy cast, the patient very likely has ATN. If you see white cells or white cell cast or urine eosinophils, they could have interstitial nephritis or pyelonephritis. If they have red cell cast or abnormal appearing red cells, they could have a vasculitis or a glomerulonephritis. If they have proteinuria, hematuria with abnormal red cells and red cells cast, that very well could be nephritic syndrome. Whereas heavy protein with fat in the urine and minimal amounts of blood is more likely nephrotic. Hyaline casts are very nonspecific casts that are seen predominantly in prerenal azotemia. So if someone's pretty volume depleted, they will have a fair amount of hyaline cast present. If you see white cells, red cells, and maybe bacteria, it's a sign of an infection. So that's something I would like you to try to memorize and remember for the rest of your life. It'll be helpful.